I asked the organizers of this meeting, what does this mean, that the talk that's listed in there? And they couldn't tell me. So this is the talk that they said, you know what, we'd rather hear you do this. And so I said, okay, I can do that, because I understand what that means. So I think that we think about exercise and intervention in the wrong way. Many people approach this as a zero-sum game issue, where either I win, you lose, or you lose, I win. But really, I really think it's a non-zero game, zero-sum game. It's not as though there's a competition between treatments. No one has ever had a mud wrestling fight about thiazides versus Lasix, right? This just sounds stupid when you say it out loud. And so the idea that one treatment is better and stands alone by itself and should cause the trashing of everything else is ridiculous. And so when I think about the conceptual framework, I don't really care if the dinosaurs were rendered extinct by an asteroid or massive volcanic eruptions, or both. However I can get to the end zone is how I want to get there, to totally mix up metaphors. So what we can see here, and what everybody in this room knows, is that intermittent claudication makes people feel terrible. So if you take a look at physical component summary scores, the average well adult scores somewhere in the range of about 55, the average adult about 50, and then we get moved down to the disease scores where chronic lung disease and congestive heart failure, New York Heart Association Class 3, puts you between the 34 and 38 range. Patients with intermittent claudication fit right in there. They feel entirely disabled. So any way that we can move them closer to at least average adult is a good thing. And the question really is there any therapy individually that does that? So Michael mentioned to you the decision summary for supervised exercise. And I think that the most important part of this is that you can now offer it. Right? We used to ask people to go home and walk. We might as well have been asking them to go home and build a gym where they live so they can have treadmills with access to them. This is not like in Europe where there is much more access until now. Now I will say the last year or so has had a couple of hiccups. They wrote a decision memo incorrectly the first time. All this has been corrected, and you can get supervised exercise wherever there is rehabilitation provided. All right, so I'm going to go a little bit more into clever than Michael did, as he mentioned. And this is not surprising data, okay? But as everybody remembers, with a 3 times per week walking program that was supervised, the increase in walking distance was significantly greater with exercise than it was with stenting. And both were significantly greater than optimal medical therapy, which was basically silostazole. And as we all know, has never been the cure-all for anything. However, I think it should be noted that the time to pain onset was actually better in the stenting arm. So basically people got used to walking with a bit of pain more, and even though they could walk longer, the time until they got pain, which is really important, so people think about, when will I have to stop because I'm getting pain in my legs? That actually took a longer period of time with the stenting arm than it did with the exercise arm. I think one of the key things, and this really builds on what Michael was saying about what patients like to do and don't like to do, is that the walking impairments questionnaire scores were much better for stenting. People were much happier with how they felt. This is another questionnaire, same thing. And I want to make the point here that no matter which score we use, nobody gets to normal in either setting. So it's not like you give one therapy and someone's perfect. Now, ERASE answers the question, at least the question that I have in my mind is, are these therapies doing the same thing or are they complementary? Are they improving walking by doing different things to people so that the benefits may be aggregate rather than overlapping? And what you can see here in the ERASE trial is that here are the patients on top who got both revascularization versus supervised exercise alone, and the people who went on to need some kind of additional therapies was much lower in the group that got both up front. Not surprising. What I think is really interesting, and just take a look at the 12-month numbers down here, the distance increase by for walking by exercise was about 955 meters versus 1,237 meters for intervention plus exercise. And pain-free walking distance had the same kind of pattern. Again, 700 for the exercise versus 1,100 for both. And so these therapies clearly add on to each other. I'm not saying that there are some people who do exercise and then don't need intervention. I'm sure there are some of those. But there are also patients who will clearly gain benefit by having both therapies because I think they're complementary. In the quality of life measures, again, we see the same pattern that we saw before. First of all, whether you want to use the VASQ-QOL score or the SF-36 physical conditioning score, the scores increased dramatically in both, but they increased much more in the arm that had both stenting and exercise compared to those that didn't. And so I think so far what I'm being able to tell you is that the combination of therapies in the right patients improves physical functioning and improves perception of wellness. I think we should start with supervised exercise, but I don't think that we should eliminate the possibility of revascularization if someone is still limited in their ability to walk, because we can see that the therapies are additive. Now, I remember I had to talk about medical therapy, so I thought I'd put in one medical therapy slide. This work is 20 years old now. The best part about this study is that it compared cilostazol to pentoxifylline and placebo. And you can see here that over a course of repeated exercise tests, there was a significant increase in walking distance of cilostazol compared to placebo of about 40 meters. And pentoxifylline did nothing. So do not use pentoxifylline for this indication. So with that, what I'll say is that both supervised exercise and revascularization improve walking distance in aortoiliac disease. These treatments likely affect different pathophysiologic components as they together work better than they do alone. And the goal for therapy should be normalization of walking ability, not my therapy is better than yours. I would say you might as well throw on cilostazol if the patient is a candidate for it. My real experience has been some people walk a lot better and almost half the people don't notice a change at all. With that, I'll say thanks, and I look forward to talking to you when we're doing the panel.